Hello and welcome to your OB course. This is fetal heart rate monitoring part 2. First, we're going to talk about the monitoring paper. It's important that we understand what the paper looks like and what it means in order to fully understand how, when we talk about a heart rate of 125, what does that mean and how does that look on paper? So over here, as you can see, you have it tells you that each one of these little boxes is 10 seconds. Okay, so the first one, 10 seconds, 10 seconds, 10 seconds, 10 seconds, 10, and 10. So if you count, we have 6 little boxes. So from this bolded vertical line to this bolded vertical line, we have over here 1 minute, as you can see. Okay, so in terms of time, we move from left to right. Okay, 10 seconds, 10, 10, 10, 1 minute, 2 minutes, 3 minutes, etc. In terms of the heartbeat, all right, we talk about the beats per minute. The paper shows from 30 all the way to 240. I hope you never have to see a heartbeat of 30 or 240. All right, the parameters that we look at and what we expect range from 110 to 160. So it's very narrow from here to here. All right, so it's important that you guys know that. So when I talk about my fetal heart baseline is 125, it means that my heart rate resides between the 120 little line and the 130 little line, somewhere in the middle. And I would categorize that as 125. Right, so just so that you guys have an understanding. When we're looking at contractions, if your contraction starts here where we can see that 0, and then it goes all the way up and it peaks and then it comes back down by the time it's, at the other bolded line, it means the duration of your contraction was 1 minute. If we are doing external fetal monitoring, the height of the contraction doesn't really tell us anything, because external fetal monitoring really does not measure the intensity. It just lets you know that there was a contraction. The only time that we utilize these numbers is when we have an IUPC or intrauterine pressure catheter, which is able to accurately measure the intensity of the contraction. And we would count Montevideo units, which we're not going to cover, but it's just so that you know that exists. So back to baseline, it's important that we understand what baseline means. In this case, the baseline of the fetal heart rate, or always in Emma's case, it's the average fetal heart rate over 10 minutes, rounded to the nearest 5th beat per minute. In this case, the fetal heart rate is, or the baseline is 145. The picture's a little blurry, but as you can see, 150 is up here. Right below it is 140, 130, 120. But the baseline or the tracing is shown somehow in between the 150 and the 140. So I'm not going to say it's 142 or 143 or 144. I'm going to say it's 145 because it's somewhere in the middle. It doesn't reside right over the 140 or right over the 150. It's somewhere in the middle. So if it's somewhere in the middle, I go for the 145. Right? In this case, if we look at it, I will tell you that this is minimal, almost absent variability. Okay, it's not absent because we see some deflections and accelerations or inflections on the picture here. Down here, it has nothing to do with the fetal baseline, but I just want to show you we have contractions. Okay, the beginning of the contraction is when it starts going up from that 0 point, all right, or from the very bottom of it. That's when we start counting. So if I were to count the duration of this first contraction, you'll see that it has one little box, 2, 3, 4, 5, 6, and a little bit more. Okay, so I would say the duration of this contraction is 60 to 70 seconds. All right, and then this one, 1, 2, 3, 4, a little bit 5, and then maybe a little bit more. So the duration of the second one is maybe 50. And then this one is a little bit longer, probably 1, 2, 3, 4, 5, 6, 7. So if I were to look at this strip and kind of take a range, I would say that the Contractions are 50 to 70 seconds in duration. I know you guys are familiar with this picture, but just as a refresher, again, we have accelerations. It means your baby's well oxygenated. We want to see accelerations. Variable decelerations means there's cord compression. It can happen for an array of reasons. We'll talk about it more later. And it doesn't necessarily have to be related to the contraction pattern. The late decelerations, you can only identify this type of deceleration as late if you are able to see the contractions. Okay, because the deceleration begins at the peak of the contraction and it's indicative of uteroplacental insufficiency. Okay, so this is something we do not want to see. It means fetal distress. Those placental reserves have been exhausted, and if it occurs once, it's okay. Nobody freaks out. But if it continues to happen, if it's a recurrent issue, a repetitive issue, or if they're very severe, meaning they go, really low and they last a prolonged period of time, then we are concerned and we want to make sure that the baby is delivered as quickly as possible. So according to ACOG, there is a 3-tiered system for fetal heart rate tracing. So we have what we call categories, right? We have category 1, 2, and 3. Category 2 is quite extensive, okay? The criteria so that your category 2 is kind of long. However, if you look at category 1 and category 3, they're kind of limited. So my recommendation to you is to truly know category 1 and truly know category 3. And then everything else that's not a 1 or a 3, has to be a category 2. So category 1 is what we strive for. This is what we want, okay? Category 1 fetal heart tracings are normal. This is what we want. It's what's expected. They are strongly predictive of normal fetal acid-base balance. They may be followed in a routine manner and no action is required. So if your fetal strip is a category 1, you as a nurse, you document and you hope that it continues to be a category 1. So what is the criteria to be a category 1? The baseline, which we've already discussed, must be between 110 and 160. Okay, that variability or the fluctuation from baseline must be moderate. You cannot have any late or variable decelerations. So if you have a beautiful strip and you have a variable, it's no longer a category 1. Category 1 is very strict, remember that. If you have a perfect strip and all of a sudden you have one late deceleration, it's no longer a category 1, it just became a category 2. If you have a beautiful strip with no lates or no variables, but your variability is minimal, even if you have accelerations, if all of your variability is minimal and maybe you have one acceleration, it's no longer a category 1. So variability must be moderate. Early decelerations, and I talked a little bit about this in part 1. Early decelerations in a category 1 may or may not be present. Why are these decelerations okay? Because this type of deceleration occurs when the baby's head is descending into the birth canal, okay? And the head compression, it's indicative of head compression, which occurs when the mom contracts and the baby is descending through the birth canal, which means it's a normal finding, it's an expected finding. On a fetal monitoring strip, this type of deceleration mirrors the contraction. So it occurs with the contraction at the same time. And if it occurs, it is the only deceleration that is acceptable in a category 1. Accelerations don't necessarily have to be present and you could still be a category 1. As long as you have moderate variability, you may or may not have accelerations. So this tells you that moderate variability is what indicates good oxygenation, all right? Then we have a category 2. I'm not going to get into that. We're just going to go to category 3, and you need to know that everything that's not a 1 or a 3, it's a category 2. So a category 3, it's very simple. Number 1, you have absent variability. What is absent variability? A flat line. Okay, it could be 120, 120 beats per minute, 110, 140. It could be within the 110 and 160 baseline. but it's a flat line. We know that if you look at an EKG and you have a flat line, we're in trouble, right? Well, with a fetal heart rate tracing, it's the same thing, okay? But you must have an absent variability or a flat line with, there's an additional condition, recurrent late decelerations, not a flat line with one late deceleration, but a flat line with recurrent late decelerations, or a flat line, meaning absent variability, with recurrent variable decelerations, or a flat line with bradycardia, okay? So if you have a flat line at 90 beats per minute, that's a category 3. It's a scary, ominous finding, okay? If you have a flat line with recurrent variables, so she has 1 variable, 2 variables, 3 variables, and flat line, it's a category 3. Or a flat line with late decelerations. Flat line, and every time the patient has a contraction, she has a late. Another contraction, a late. Another contraction, a late. That would be a category 3, which means we have to get this baby delivered stat, okay? The other finding that makes it a category 3, and we're going to look at some pictures, is a sinusoidal pattern. This is that undulating, serpentine-looking pattern that is indicative of fetal distress, okay? And this is an ominous finding. We do not want to see it, and if we do, we want to make sure that we can get this baby delivered ASAP. Okay, so this is again just the definition of category 1 and category 2 and 3. Please note, anything that doesn't mean the strict requirements or definition of a category 1 or a category 3 automatically becomes a category 2. So for example, if I have absent variability, a flat line, but I have, it's within my range of 110, 160, and I have no variables, no decelerations, even though it's a flat line and it looks really ugly, it's still a category 2. Please understand there's different types of category 2s. You might have a category 2 that almost looks like a category 1, okay? This is that perfect strip with accelerations and variability, but then boom, you had 1 variable. So because of that 1 variable, it stops being a category 1 and it becomes a category 2, all right? And then that's a good category 2, right? You still wanna maybe reposition your patient and do something because you don't want a variable. But then you also have category 2s, like the example I just gave, where you have a flat line, let's say of 110, baseline 110, but there is absent variability, okay? It's ugly, but because it doesn't have any decelerations, no variable, no lates, it's still only a category 2. Now, we have 2 extremes of category 2. The one that looks beautiful with moderate variability, you know that baby's great, but has 1 variable, category 2. And then you have this baby that has 0 variability, which means there are no reserves, but there are no decelerations. So which means it's still a category 2. Am I going to respond to these category 2s in the same manner? Absolutely not, okay? The one that's a flat line with 0 variability, I'm probably going to be a little bit more aggressive in treating than the one that's perfect with 1 variable, okay? With a category 3 tracing, it's an abnormal finding. They're predictive of abnormal fetal base status and require prompt evaluation. Depending on the clinical situation, intrauterine resuscitation should be initiated. And that we're going to see in another presentation, what entails intrauterine resuscitation. Okay, so that's important to know. We act. If you identify a category 3, this is not the time to think, to analyze, to maybe stand by and watch and hope that it gets better. No, you need to be performing interventions. Otherwise, your baby's not going to make it. So the 3-tier fetal FHR interpretation system, again, category 1 is normal, and then these are the requirements, and this is what it looks like. I wanted you guys to see this. You see the variability here. It goes up and down, up and down, up and down, etc. It's beautiful. The baseline, it's between our desired 110 to 160. If I had to guess here, I would say my baseline is 125, all right? In terms of the contractions, this patient's having contractions, nothing to write home about. There are no late decelerations. There are no variables. It's just moderate variability. It is excellent, okay? And that's what it looks like. This is another sample of category 1, okay? As you can see, moderate variability to category 1. You have a baseline. You see where you have these little dotted, that's your baseline. That's how you identify your baseline. You have at least 2 minutes of that. All right, but then above and below the baseline, you have accelerations, you have all kinds of things going on. So it has moderate variability. This is also a category 1. Category 2, or indeterminate. These are the ones that you have to intervene so that it does not become a category 3. All right, and it may include any of the following: bradycardia, tachycardia, minimal baseline variability, absent baseline variability not accompanied by recurrent decelerations of any kind, marked baseline variability, absence of induced acceleration, recurrent variable decelerations with minimal or moderate variability, prolonged decels, recurrent late decels with moderate variability, variable decelerations with other characteristics. So in essence, anything that is not a strict category 1 or a strict category 3 is considered indeterminate category 2. Category 3, it's abnormal, and this is what it looks like. In this picture, as you can see, the baseline, it's about 185. Very scary. I mean, not 185, it's 85 beats per minute. So this is bradycardia. And on top of bradycardia, because it's below our desired 110 minimum, it also has absent variability. Okay, so in this case, it's absent variability with bradycardia. All right, so very scary, very, very scary. This baby must be delivered stat, and you have to hope and pray that they're still alive. Okay. This is another example of a category 3. Okay, as you can see here, the patient has a contraction, and with every contraction, she's having a late deceleration. Remember, late deceleration is the baby's heart rate starts to drop at the peak of the contraction. So here you see it, it drops. She has another contraction, and at the peak of the contraction, it starts to drop. And then the next contraction, and you could see that it's another deceleration. And it has 0 variability. Now, if I had this same exact strip, but I had moderate variability, it would not be a category 3. Or minimal variability, let's not say moderate. Minimal variability, it would be a category 2 that I would be performing interventions on, because I need to make sure that it gets out from there, or that the late deceleration stop happening, because if not, it's quickly going to become a category 3. And again, we'll talk about interventions in the next presentation, intrauterine resuscitation. But this is another category 3. The infamous sinusoidal pattern. As you can see in the top, you can't really identify a baseline. It's kind of like a little serpentine. And even though it's within that desired parameter of 110 to 160, this is an ominous finding. They are regular, smooth, undulating form, typical of a sine wave that occurs with a frequency of 2 to 5 cycles per minute and an amplitude range of 5 to 15 beats per minute. Okay, so they could be little, 5, or they could be 15 beats. The amplitude could be up to 15 beats per minute. Sinusoidal pattern. Please note there is such a thing as a pseudo sinusoidal pattern. So you'll have a strip that looks like this, but your baby's not really in distress. It could be that they are sucking on their thumb, or it could be that mom was given a medication, some type of anesthetic, maybe magnesium, maybe some type of medication that changes the baby's heart rate. So how do we know which one's the true sinusoidal pattern and which one's the pseudo? A pseudo sinusoidal pattern can be broken. Okay, if I have this pattern and I reposition my client and the pattern changes, then it wasn't a true sinusoidal pattern. Are you going to wait for 20 minutes to intervene? Absolutely not. The minute you see 1 or 2 minutes of this, you're concerned. You need to be performing interventions and making sure that you break that pattern. If you cannot break the sinusoidal pattern, then it is a true sinusoidal pattern and it's an emergency and the baby must be delivered. Here I just have another picture of what we call, I had not shown you guys a picture of an early deceleration. As you can see, it mirrors. As the contraction starts, the deceleration starts. The nadir, or the lowest part of the deceleration, almost kisses the peak of the contraction. You see, so it mirrors the contraction. That's an early deceleration. This is a late deceleration. Again, contraction starts here, the deceleration starts here, etc. And then a variable, you have it where it's a quick, drop from baseline. So it doesn't take a long time to reach the nadir. And it could be related or not related to the contraction. And then this is just something for you guys to laugh. It says, it's okay to be early for dinner, but don't be late. Remember that. So it's okay to be early. So if you have early decelerations, we're not concerned. But if you're late, you're in trouble. So I just have a review question here. Interpretation of variability for this strip would be, what does this look like? Is it moderate? Is it minimal? Is it absent? Is it marked? What kind of variability do we have this? By the way, it's not average variability. It should be moderate variability. And that is your answer. That is moderate variability. Okay, remember the amplitude of moderate variability is from 6 beats to 25. Interpretation of decelerations for the strip would be, what kind of decelerations are these? Okay, are they late? Are they early? Are they variable? What are they? Variable decelerations. They are abrupt, visually apparent decrease in fetal heart rate associated with cord compression. Then we have interpretation of the baseline for this strip would be, this baseline, what is the baseline? So I'm looking at this, okay? And yeah, it goes over at 180. It's definitely above 160, which is outside of my parameter. And it's above that. So we would say it is tachycardia. Okay, baseline rate above 160. Usual reason for tachycardia is fever. Not fetal fever, maternal fever. When mom has a fever, you'll usually see on the fetal strip that the baby has tachycardia. So we must treat mom for the fever in order to decrease the fetal tachycardia. Sometimes it can also happen due to dehydration. And then these are some fetal monitoring patterns for you guys to view. Healthy acceleration. Remember, look at this. This is the category 3. You have no variability in recurrent late decelerations. And then over here, you have variable decelerations, which is a quick drop. And in this case, you have what we call shoulders. The deceleration is preceded and proceeded by an acceleration. Okay, some variables look like a W or a V. All right. And then these are severe variable decelerations. They go really deep. As you can see, they go to as low as below 60, maybe 50 beats per minute. So again, this is a lot of fun to learn. I hope that this does spike your curiosity and that you go back and review and learn more about fetal monitoring. Until next time.